Hi everyone. So my topic is the effectiveness of chemotherapy on patients with early stage glioblastoma cancer compared to late stage glioblastoma cancer. So why did I pick it? Because glioblastoma cancer accounts for over 60% of all brain tumors in adults, and despite numerous scientific developments like CRISPR and other technologies and treatments, glioblastoma cancer still has a very poor prognosis. Through this report, I want to raise awareness and inform all citizens of the deadly disease and its devastating effects on the human population in an attempt to collectively take a step towards saving 31,922 lives every year. So, because anyone and everyone can make a change. So, glioblastoma cancer, or glioblastoma multiforme, is a malignant tumor that affects the brain, specifically the cerebrum and/or the spine. The tumor grows and spreads aggressively, often creating pressure on the brain or the upper back. So GBM forms from cells called astrocytes that support nerve cells and the tumor and can grow at any age. However, it tends to occur more frequently in older adults to senior citizens. Common GBM symptoms may include headaches, nausea, drowsiness, blurred vision, personality changes, or seizures. And common treatments of glioblastoma cancer include chemotherapy, radiation, and surgery. So my scientific hypothesis was that if glioblastoma patients are diagnosed in the early stages of cancer, which is grades 1 or 2, then they have a better chance of surviving longer than patients who are diagnosed in the late stages of GBM, which are grades 3 or 4, because the rate of cancer cell growth can be more controlled effectively with chemo in the early stage. So the null hypothesis was if GBM is detected in the late stage, grades 3 or 4, or early stage, grades 1 or 2, then there will be no effect on patient survival time after chemotherapy. Yep. So this is what GBM looks like, and in the early stage, it's visible that the cerebrum is much less affected, indicating early stage glioblastoma cancer, so stages grades 1 or 2. And then on the late stage, the cancer has aggressively spread through the cerebrum, usually indicating a more severe diagnosis, stages 3 or 4. So the first step of my methodology was outsourcing the scientific research for datasets. So the scientific research and field experts were contacted via email and phone for assistance with how to interpret given data and understand the statistics. If I needed further assistance, then I contacted the appropriate mentor under the University of Sydney mentorship. Several studies and student-made reports were shared via email. The second step of the method was to cleanse the data. So once the data was collected and sorted according to relevance, it was collectively arranged into 2 separate sections, early stage or late stage glioblastoma. Rearranging the data allowed me to cleanse the statistics and gain a deeper understanding of the research because only what was relevant to the report would be saved. Step 3 was implementing the statistical analysis. Once the data was arranged into the Excel sheets, a statistical analysis was conducted. First, I conducted an F-test, and to determine if the variances were equal or unequal. Next, a t-test assuming equal variances was conducted to compare the 2 groups. This was done to test the scientific hypothesis, and the t-test results also helped solidify the rejection or accepting of the null hypothesis. And the last step was compiling the scientific report. I included all the basic conventional parts of the scientific report like a title, abstract, literature review, scientific research questions, scientific hypothesis, methodology, results, and discussions and conclusions. And in the end, if further assistance was needed, then I contacted my teacher for verbal feedback. The results show that the F-test shows that the 2 datasets have an equal variance as the F-stat critical value equals 1.5871 and the F-critical equals to 2.1938. Hence, the null hypothesis can be accepted as the results suggest that GBM stages will have no effect on patient survival after chemo. The t-test results were that the t-test value equals negative 1.149 and the t-critical equals 1.678, suggesting that the null hypothesis can be accepted as the t-critical value is larger. This is also confirmed by the p-value being larger than 0.05. Accepting the null hypothesis, if glioblastoma cancer is detected in the late stage or early stage, then there will be no effect on patient survival time after chemotherapy. secondary data evaluation, I used several studies conducted by the AANS who rejected the null hypothesis. Specifically, the study was conducted by Dr. Vikram C, who evidently suggested that late-stage glioblastoma cancer reduces the efficiency of chemotherapy, as cancer cells have spread more toxins in the late stage of glioblastoma patients. However, this may have significant bias in the study, as the study was conducted to support data sets from previously completed studies. In the future, the null hypothesis may be rejected if scientists consider clinical factors like age at diagnosis, gender, family history, demographics, nationality, and lifestyle choices in their research. Implications for the future research include researchers having to consider all those factors before accepting or rejecting the null hypothesis. And the concluding judgment, overall, based on the statistical evidence, the null hypothesis should be accepted unless proven otherwise by future research that takes into account clinical factors that may affect outcomes of GBM when treated with chemotherapy. These are some sources that I used, and that's it. Thank you.